Dear colleagues, dear Chairman, thank you very much for your kind invitation to present on clinical inertia in diabetes and present the verify results to you in the context of the virtual Axon Pharma Symposium at your conference. It's a great honor, and I would first like to disclose any potential conflict of interest. Of course, the verify study was performed by Novartis Pharma, but I can assure you that none of the entities mentioned here had any influence of the content of my presentation. When we are talking about the treatment of patients with type 2 diabetes, we have to consider that as early as in the Egyptian times, 3,500 years ago, there was already treatment options which were plant-based. But of course, they haven't been investigated in randomized clinical trials. In the last 100 years, the choice for the treatment of patients with type 2 diabetes has expanded to 11 categories and 28 different medications we can now use. So this first means that we can better personalize and individualize treatment of those patients. But this also means that the choice can be challenging because of its complexity, and this may contribute to clinical inertia, that we do not take advantage of this full spectrum of medications available these days. We are talking about the European and American Diabetes Association consensus statement, which demonstrates the complexity, although it's not so complex at all, because we only have to ask the patient and ourselves three important questions. First, does my patient have established cardiovascular disease, heart failure, or kidney deficiency? This is approximately to be answered with yes for 20% of our patients. Approximately 80% of the patients do not have a cardiovascular manifestation. In those patients, I have to ask, is weight loss your major goal, or do you want to minimize the risk associated with treatment such as hypoglycemia? Or in the third instance, do I have to save money and have to go for a not as expensive treatment strategy? What is frequently forgotten in this context is this little ball on the right corner. And this says we should be attend to the fact to avoid clinical inertia and modify the treatment every 3 to 6 months for our patients. Indeed, despite the breadth of therapeutic options, there are significant challenges for our patients with type 2 diabetes. First, we are still not able to prevent new cases of diabetes in groups which are at risk. Secondly, there is still suboptimal treatment strategies to slow down the progression of the disease itself. Many of our patients do not achieve treatment goals to reduce or prevent even the risk of diabetes complications. And of course, there is inadequate access to optimal care around the world. How do we define our glycemic targets? And they have been defined basically on the results of the UK PDS trial, because the trial showed that maybe for macrovascular disease, such as myocardial infarction, we have a long range of HbA1c. Of course, it's a linear relationship between increasing HbA1c and the risk of cardiovascular diseases, but we don't have really a starting point. Whereas if we go to microvascular complications such as retinopathy, shown on the right-hand side, we see that the risk to develop microvascular diseases increases significantly, starting at a HbA1c of approximately 6.5 to 7%. So the target range for our patients with type 2 diabetes would be a glycemic control HbA1c below 7%. Unfortunately, with our conservative approach to treat hyperglycemia, we are always running behind our patients and a good glycemic control. So we typically treat with diet and exercise first until blood glucose goes up. Then we start with metformin. This, of course, works also for a while, but it usually increases the risk for a failure. The problem is that this stepwise approach often leads to treatment failure with long periods of high glucose and even glucose toxicity. In other words, our patients experience long phases of chronic hyperglycemia. This could be put into numbers. So the true numbers behind that treatment inertia, meaning patients who live with an HbA1c above 7%, accounts to up to 10 years in the individual history of our patients. So the decision from metformin to a dual oral antidiabetic treatment usually is delayed between 2 to 3 years. The dual therapy to a triple combination or a combination with a GLP-1 receptor agonist is usually delayed by another 7 years. And if we talk about insulin initiation, we are also talking about between 6 and 7 years of inertia and treatment delay. So you may argue that this stepwise approach is, of course, a good quality of life for the patient because we don't overtreat the patient. But real-world evidence confirmed that a delayed intensification after a failing monotherapy can lead to significantly increased side effects and complications. Indeed, if you look at the numbers across the world of HbA1c when a combination therapy is prescribed, we are talking about an HbA1c either of 7.7 up to 8.6%. In other words, those patients are already 1.6 HbA1c points above the target, and they live with these values for many, many years, as I shared with you. And against this knowledge, I have to admit that I was surprised to see the impact of only 12 months of treatment delay or inertia. In a cohort of more than 110,000 patients from the United Kingdom treated between May 1990 and January 2020, a treatment delay was observed in 26% of all patients. So all these patients which had a delayed intensification of treatment after they have a HbA1c above 7% translated into 67% more myocardial infarctions, a higher risk for stroke of approximately 50%, heart failure 64%, composite cardiovascular endpoints increased by 62% only 5 years later. So in other words, we can not only save lives, we can also prevent those really unnecessary cardiovascular events, which are simply caused by treatment inertia. Clinical inertia is defined as a failure to initiate or intensify treatment in a timely manner in people with diabetes whose health is likely to improve through a therapeutic intensification. Indeed, a failure to establish appropriate targets and to escalate treatment to achieve target goals should be one of the primary goals of our treatment intensification. On the other hand, inertia is not only a problem for healthcare professionals. Of course, it also affects patients. We are talking about non-adherence to behavioral modification, poor understanding of the treatment, attitudes against medications, for instance, influenced by media and others, or the fear of side effects. Also, physicians or healthcare professionals may overrate the quality of their care. They use soft excuses such as lack of time. They blame the patient for being non-compliant or adherent. They do not provide appropriate support. The challenge is also to implement current guidelines and really to individualize treatment goals. And we are used to this slow, stepwise approach for treatment intensification. There are also systemic contributors to clinical inertia. The older guidelines promote the old algorithm. Primary care physicians tend to operate in isolation. There are time constraints. I mean, we are all under time pressure. You know better than I do. Maybe there's also a lack of organizational mechanisms to support physicians and to monitor treatment success. Indeed, the current treatment algorithms and guidelines for the management of high blood sugar levels say that there is now support for initial combination therapy and early as possible intensification of treatment. And this statement is based on the VERIFY trial, which I would like to introduce to you in the second half of my presentation. An initial combination therapy, such as 2 oral antidiabetic medications, may be considered in patients who have an HbA1c level 1.5% above their target. I already mentioned quickly the VERIFY trial, because this changed really how we think about intensification of treatment. This is kind of a paradigm shift. The first paradigm shift was the UK PDS trial, which set the HbA1c targets below 7% HbA1c to avoid retinopathy. The VERIFY trial is distinct from all the other large clinical trials in the diabetes field, which, as the VADT, the LEADER, the DECLARE, and others, started only in those patients who had already 10 years of diabetes duration. Only the ADAPT trial, the UK PDS, and now the VERIFY investigated freshly or newly diagnosed patients with type 2 diabetes. The VERIFY trial is also distinguished from all other trials because it is started in a very low HbA1c level below 7%. So it really started at the point we should think about treatment intensification. Here you can see the context of the VERIFY compared to other studies. Indeed, the rationale for the VERIFY trial was to say, can we improve the quality of glucose control, may protect patients from side effects if we use a very early treatment intensification strategy. And this was performed through an early initiation of the combination of 2 oral anti-diabetes agents, metformin and a DPP-4 inhibitor, to achieve the best possible glycemic control very early in the history of the disease. The VERIFY trial was a randomized, double-blind, 2-arm and parallel group study, which consisted of a screening visit and a 3 weeks run-in period. The primary goal of the study was to delay the treatment failure of the first diabetes treatment strategy. The observation period and treatment period was a 5-year treatment period during which patients' treatment was consecutively intensified if clinically indicated. The VERIFY trial was a multinational and multi-ethnic study involving 254 centers across 34 countries in 2001 people. And you can see here also in Latin America, unfortunately, Chile was not part of it, but many other countries across the world were part of the VERIFY trial. VERIFY included patients at an age between 18 and 70, with a BMI between 22 and 40, and in a very narrow and low range of HbA1c between 6.5 and 7.5. That is the most important criterion because it demonstrates that here the trial targets very early development of the disease, to hit early and hard if you want so. A GFR was defined above 60. The type 2 diabetes diagnosis shouldn't be older than 24 months, and patients should be drug naive. Maximally 4 weeks of metformin were allowed. So these were the key inclusion criteria. The study started in patients with newly diagnosed diabetes with diet and exercise failure, 24 months from diagnosis, as I said, with a run-in period with increasing dose of metformin starting from 500 to 1.5 grams per day metformin before randomization. Then patients were randomized in an early intensified treatment combination with metformin and vildagliptin, 50 milligrams twice a day, or metformin only. Primary endpoint was the time until failure. The treatment failure was defined as the HbA1c above 7%. Here you can see the example of a patient who would have an early treatment failure as early as at 6 months. The Verify didn't rely on just one HbA1c measurements. You need to have 2 consecutive HbA1c values above 7% to get the diagnosis of treatment failure. So the earliest treatment failure, therefore, would be 6 months after the treatment. Here you see again the HbA1c, which is shown here in the dotted line, a patient who developed a treatment failure 9 months after the initiation of the treatment. Because after 3 months, he or she was still in range, but at 6 and 9 months, HbA1c was above target. And here you see the perfect example of a patient who would have no treatment failure. HbA1c was always across 60 months of the study duration below 7%. But there was also defined a secondary failure. The primary outcome addressed the question, do those patients with diabetes benefit from having a combined therapy right at the beginning of their pharmacological treatment? The second question was, of course, in the period 2, patients who failed stayed on the combination, and those who not failed, they were continued. If patients on metformin didn't fail, no intensification was necessary. If patients on metformin only failed on therapy, they moved to the combination with vildagliptin automatically. This was defined as the time to second failure if the combination therapy of metformin and vildagliptin was not sufficient to keep the HbA1c below 7%. And the next treatment step in period 3 was the initiation of insulin. So the first period defined the early treatment failure. The second defined the treatment failure of the combination therapy. And the third period was then the state-of-the-art insulin treatment. The baseline characteristics of the Verify population are shown here. Both groups were very well matched. Approximately 50% were women. The age was 54 years. The duration of diabetes in months was only 3. HbA1c as a mean was 6.7%. Again, the Verify trial is the only trial which started with such a low mean HbA1c. BMI in the light obesity range with 31, and the GFR was in 40% normal. 15% were current smokers. Here, I would like to show you the most important outcome of the Verify trial, the primary endpoint, which has been defined as the time to initial treatment failure. Here, you see the graph of patients who had a treatment failure on the y-axis and the curve for those who started on metformin only. The blue line demonstrates those patients who started with metformin plus vildagliptin. And you can see this was associated with a significant reduction in early treatment failure. You can put that, of course, in numbers. So the initial monotherapy of metformin was able to keep people under control for 36 months SME. Not that bad, 3 years. But if you had a patient who received an early combination, the time point of the treatment failure could be delayed up to 61.9 months. So we are talking about 2 years difference here. I introduced also the concept of the second failure, the question if a patient who had then the combination of vildagliptin and metformin needed insulin after the second phase. Here you see the curve for the initial monotherapy over 60 months. And again, also for the second failure, the early combination therapy achieved significantly lower event rates. In other words, you could extend the time where patients were under control significantly compared to the initial monotherapy. In other words, there was a positive glycemic memory in the patients, which helped the patients, even if they had a secondary failure, to be less affected than if they only started with metformin. If we go into detail of the VERIFY study and look into subgroup analysis, you see that overall, the early combination is favored at all categories. And it didn't make a difference if the HbA1c was either below or above 7%, if a patient had obesity or not. The age didn't play a role. It was successful both in men and women. Smoking status did not affect the positive outcome of the early combination therapy. The same is true for the race. There was no strong effect on race. Only for the geographical region, you see here this outlier, but this is caused by the fact that only 4 patients from Australia were included into the trial, and they, of course, had a high variation. But for all other groups, there was no significant effect or interaction for the outcome which favored early combination of metformin plus vildagliptin. Interestingly, although statistically not significantly different, the initial monotherapy was associated with a slightly lower weight reduction curve, but also in the early combination, and this may be due to the fact that you had better glycemic control and less glucose loss in the urine, if you want so. And that makes sense that the early combination is slightly higher in the weight, but still reduced weight over the period of 60 months. If we go into clinical practice, we would expect that body weight increases normally over that period in patients treated for type 2 diabetes. So that's also a good outcome. Talking about the beneficial effects and the primary outcome, we also have to consider safety events. And I can assure you here that there was no difference in the number and also in the frequency of patients who experienced adverse events. Same is true for serious adverse events, drug-related, and other adverse events that led, for instance, to discontinuation. There was also no signal for that increased death rate, for instance. Even if the numbers may be different in the groups, there was no effect which caused any worries about the safety of this treatment. There are, of course, specific interest terms which have been investigated, such as arthralgia, benign neoplasms, or also malignancies, but there was no signal for pancreatic cancer, prostate, breast cancer, ovarian cysts, and other specifically predefined adverse events. So very safe and well-tolerated treatment strategy, considering the early combination. I think this is something we expected from two well-tolerated medications, metformin and the DPP-4 inhibitor, vildagliptin. Most interestingly, but of course statistically a little bit critical to discuss, the question, can you, with the early combination therapy, maybe help the patient to delay cardiovascular diseases and events? Of course, the Verify was not a cardiovascular outcome trial. All the cardiovascular events were subject to adjudication by a committee, which was independent and masked, and safety monitoring board. But now, if you can see here, simply taking the cumulative number of recurrent events, we are talking about a difference between 30 events in the early combination, whereas the initial monotherapy experienced 44 events. That was, although statistically not significant, a strong and impressive difference, speaking again for an early combination therapy. It may also suggest that if we continue to reduce hyperglycemia, to reduce glucose toxicity from the beginning with an early combination therapy, that we may even expect cardiovascular benefits from that. Of course, there is a caveat, because we are only talking about small numbers of events and a wide confidence interval. Therefore, the statistically significant difference could not be established, but at least it's a trend. Here you see again the statistical p-value for the same curve. It's indicative, and we think that we need now more dedicated studies which test the hypothesis that an early intervention with a dual combination, for instance, with a DPP-4 inhibitor and metformin, may save against cardiovascular events if we start as early as possible. I would like to summarize the clinical implications of clinical inertia, but also the results from the Verify trial. The results from the Verify trial implicate that we can and should overcome clinical inertia, because early combination treatment halved the risk of time to initial treatment failure compared to the monotherapy strategy in the stepwise approach. So the median time to treatment failure was 3 years in the initial monotherapy, compared to more than 5 years in the early combination strategy. So we have a delay or a better glycemic control for more than 2 years in the early combination. When all patients were receiving a combination therapy, so the second period of the trial, the risk for the second treatment failure was reduced by 26%. So even at a later stage, patients continue to benefit from the good glycemic memory. And of course, both approaches were very safe and well tolerated. I'd like to conclude that the Verify trial really has the potential to change our therapeutic algorithms and changes our paradigm that we should treat patients with type 2 diabetes with a stepwise approach. The Verify trial demonstrated that you can, for significantly important outcome measures, improve glycemic control if you hit hard and early with a combination strategy. The strategy of an early combination approach with metformin plus vildagliptin in patients who had newly diagnosed type 2 diabetes consistently improved long-term glycemic durability compared with the metformin monotherapy. With this, I would like to thank you very much, muchas gracias, for your attention, and I look forward to questions you may have.